Sure. So, we are in the course of cardiorespiratory fitness, and you are dealing now the cases of respiratory abnormality. Like in the case one, you talk about the pneumothorax, which is an acute emergency condition. In the case two, you're talking about bronchial asthma, and the case three is about the chronic obstructive pulmonary diseases. Okay, so these are the three cases you are going to discuss about the respiratory part of the CRF course. So in the pathology department, we decided to take three lectures about the respiratory pathology, because when you go in the clinical practice, you will find, especially in the journal practice, you will find respiratory ailment very, very commonly. So a brief about the pathology of these diseases is really very, very important for you all to know. So in this lecture today, I'm going to talk about bronchial asthma, and one of the common condition which is not related to your case, but it is one of the important respiratory pathology which you will see very frequently, especially if you're working in intensive care unit or in emergency department. Okay, that is acute respiratory distress syndrome. So today we are going to talk about these two important diseases over here. Okay. So what are the ILOs for the today's class? Okay. So it is about the knowledge of bronchial asthma. Definition, like causes, pathogenesis, type, any morphological changes you can see in the organs, like in the lung, in the asthma, clinical presentation of the asthma, and complication. And then you have sorry for the third point, it is like just like it has been there. We don't consider that, is only we have two ILOs today. Okay, and we have the acute lung injury or ARDS. So both are the same thing, acute lung injury or ARDS. Okay, so in this also we are going to see definition, pathogenesis, pathological changes, and clinical significant. Okay, so what is bronchial asthma? So this definition of the bronchial asthma is clinico-pathological definition. Okay, why we are talking about, when you come to other class, that time we see some definition of the disease of the respiratory pathology purely clinical. Some definition of the disease is purely pathological definition. But in bronchial asthma, you have both combination, clinical and pathological. Okay. So what is the definition of asthma? Is a chronic inflammatory disorder of the airways. Okay, it is chronic inflammatory disorder of the airways, which is characterized by increased responsiveness of the tracheobronchial tree. Okay, increased responsiveness of the tracheobronchial tree, resulting in widespread but variable. Okay, so there is widespread, throughout the bronchi. You will see the bronchoconstriction, which is variable. Somewhere it is more, somewhere it is less, and there is limitation to the airflow, or obstruction or resistance to the airflow, and this resistance is partially reversible, either spontaneously or with the treatment. Okay, so there is chronic inflammatory it is a chronic inflammatory disorder in which you see the increased responsiveness of the tracheobronchial tree, characterized by the bronchoconstriction, airflow limitation, and which is partially reversible. Okay, not completely reversible, but you can reverse it either spontaneously. If it is exercise induced, you take the rest, it will go back. Okay, or if it is some allergens, you take proper treatment, it will go back, but it is partial, not completely reversible. Okay, it is an episodic disease which is manifested clinically by recurrent episodes of wheezing, breathlessness, chest tightness, and cough. Okay, usually the cough will be seen in the night and early morning, and patient will complain that his chest is tight, he is not able to breathe, and there is a typical whistle-like sound while they exhale or during the expiration. This is called wheezing. So what are the hallmark? With this definition, we can come to these hallmark feature of the disease of asthma: increase airway responsiveness to any stimuli, that could be allergens, exercise, drug, and this responsiveness will manifest with the bronchoconstriction, And what is the pathology over there? There is inflammation and there is increased mucus secretion. So this is the definition of bronchial asthma. Is it clear for all you to understand the definition of bronchial asthma?
Yes, doctor.
Yes.
Okay. So it is an episodic disease characterized by chest tightness, cough, wheezing. And what is there? There is increased air responsiveness, bronchoconstriction, inflammation, and excessive mucus secretion. So there are two types of asthma. In the clinically, we classify them as a extrinsic, allergic, or atopic asthma. This is the most common one. And the second one is the intrinsic or idiosyncratic or non-atopic asthma. So there are two types. There is another type which is like mixed type in which clinical features do not fit into any one of these. It has combination of both. Okay. So we call them mixed type. But the most common one is the allergic or atopic, followed by non-atopic asthma. Pathological type of asthma, you have extrinsic. We call them allergic or immune asthma, which could be atopic due to IgE, immunoglobulin E. It could be due to occupational, like for certain person working in the occupation, certain occupational like farmers or someone working in the cotton industries, someone working in like greenhouse where they grow the vegetable. There are high fungi. So in that they have asthma. And this is asthma mostly due to either IgE or IgG. And the third one is in the immunological or extrinsic type of allergic type of this thing. One is the bronchopulmonary aspergillosis, IgE. It is also related to IgE. And then we have non-immune asthma, which is aspirin induced infections induced due to aspirin or due to infection. Okay. So this is pathological classification where we have the cause due to IgE or atopy, due to occupational or due to this specific type of fungi, aspergillosis or uh, acute bronchopulmonary aspergillosis. This is a type of fungus, aspergilli, which may cause hyperresponsiveness of the bronchopulmonary tree, which manifest into the obstruction and asthma. Here also is IgE. So most of the extrinsic or atopic is related with Ig. A fewer new type of occupational asthma can have association with the IgG. While intrinsic or non-immune, there is no immunological response. This could be due to aspirin, or aspirin is a drug, non-steroidal anti-inflammatory drug, or it is due to the certain infection, especially the viral infections. Okay. Now, what is atopic asthma? Okay, atopic asthma is most common type of asthma, which is mainly manifested due to immunoglobulin E mediated hypersensitivity reaction. It is usually begins from the childhood and triggered by environmental allergens like allergies in the environment, like the carpet, the allergies to the clothes, to the pollen. If someone stay in the farms, pollens of flower, pollens of seeds, that can trigger the asthma. Okay, there is in the atopic asthma, there is a positive family history of asthma. Like the child, if child has asthma, he will give positive family history is in close family relatives. And very important is like there is a positive skin test, wheal and flare reaction to the allergens. If you imply that allergen or small amount of that allergen, you give subcutaneous injection of that allergen to the skin, you will find a very positive skin test in the form of wheal and flare. You see the like red color around the site of injection. The other type, which is least common, which is known as non-aerobic asthma. There is no evidence of any allergy or sensitization. So there is no allergy, no sensitization. So skin test usually will be negative. Family history of asthma is less common. There may be some positive family history, but not as strong as in the atopic asthma. Okay. As you see, the atopic asthma seen in the children, or it begins in the children. Non-atopic usually seen in the adults patient. Okay. And here history to the respiratory infection due to viruses, especially the virus which causes common cold like rhinovirus, parainfluenza, and respiratory syncytial viruses are common triggers in non-atopic asthma. There is also some allergic reaction to the air pollutions. Okay, usually the tobacco smoke, industrial gases like sulfur dioxide, ozone, nitrogen oxide also contribute to the development of non-atopic asthma. And sometimes it like there is no exposure to the infection, no exposure to the any environmental environmental gases, or no exposure to the drug. Just it can be exaggerated or can be seen by just like repeat like little bit exercise, or some exposure to the cold can also induce this non-atopic asthma. So we have atopic asthma where we have a very strong positive history with the allergy and sensitization. While here in non-atopic asthma, we don't have such history. So major differences between the atopic and non-atopic asthma, like usually extrinsic atopic, intrinsic non-atopic, age at onset in the childhood, usually in the adult. Family history commonly present here, may present, most of the time it is absent. Okay. Like atopy, some other allergy to the some food and some type of cloth or some kind of allergy will be present over here, and the symptoms of like urticaria, eczema, rhinitis, running nose will be there, while allergies are absent in the intrinsic asthma. Allergens, if you have allergies, you will be seeing allergens in extrinsic, but you will not see any allergens in the intrinsic asthma. Drug hypersensitivity, you will not have drug hypersensitivity in the extrinsic asthma, but it usually be seen especially to the aspirin. Okay. IgE very strongly related with the extrinsic asthma, but it is normal. IgE level will be normal in the intrinsic asthma. Okay. Associated chronic bronchitis, nasal polyps usually will not seen over here, but in the end, because these are the condition, chronic bronchitis are usually due to related to the cigarette smoking or environmental toxins, so it will be usually seen in the intrinsic asthma. Emphysema. Emphysema will going, which is a type of chronic obstructive pulmonary disease, which usually be seen with the intrinsic asthma, because again the same pathogens, exposure to the cigarette smoking and environmental toxins will lead to causation of the emphysema. So that will also be seen in the intrinsic asthma, but these two features will usually not seen in the atopic Ig associated extrinsic asthma. Okay, so differences between these atopic and non-atopic asthma is clear to you all?
Yes, doctor.
Doctor, I have a question.
Yes, please. Very good.
The
I am very happy
extrinsic,
with the questions. Yeah.
the extrinsic asthma is the topic asthma, and the intrinsic asthma is the non-topic asthma.
Yeah.
Oh, okay.
Yeah. Extrinsic is atopic. Why it is called extrinsic? Because it is due to some exogenous allergens, something from outside, okay, the body, and that will leading to the development of these asthma. Okay. While intrinsic, we don't know the exact cause for this. Okay. There is usually like many mechanism can lead to development of these asthma. This is slowly developing and usually seen in the adult life. That's why it is called intrinsic asthma.
Doctor,
Okay.
Yes.
I have a question.
Yes, please.
We say intrinsic asthma have no relations with the immune system, right?
Yeah, majority of the intrinsic asthma, like we have the very specific type 1 hypersensitivity reaction, IgE antibody will be seen in atopic or extrinsic asthma, but it is not related to these immunological mechanism in the non-atopic and the intrinsic asthma. Yes, you are correct.
Okay, why drug hypersensitivity is present in intrinsic asthma? Because hypersensitivity is caused by immune system?
Yes, very good question. Okay. It is when we call about the drug hypersensitivity, we don't talk about that type 1 hypersensitivity reaction. Here, actually, we want to tell drug induce. Any drug can induce the asthma. So here we don't find any drug inducing any IgE type of reaction and asthma. Okay. But here, aspirin is very, very commonly associated in the intrinsic asthma, but we don't find these reaction related with any of the IgE or any type of type 1 hypersensitivity reaction. Okay, that's why we see this is not that drug, that hypersensitivity reaction, type 1 hypersensitivity reaction. Here we just want to tell relationship with the drug. Okay.
Okay, doctor, thank you.
So now pathogenesis of atopic asthma. Whenever we talk about pathogenesis of atopic asthma, you must know about two things. Okay. What are those two things? Okay. Type or T helper cells and immunoglobulin E. Okay. These are the two things, like immunoglobulin is type E type of immunoglobulins, and which of the cells? It is the type 2 helper or CD4 T cells. Type 2 helper and CD4 T cells. And in whom it happens? It happens mostly in the genetically predisposed individual, the one who is genetically predisposed to develop these type of response, okay, to environmental allergens, okay. And whenever they get exposed to these environmental allergens, there is series of events which will lead to inflammation of the airway and hyperresponsiveness of the airways, which will bring about inflammatory cells. These inflammatory cells will produce different types of mediators, cytokines, and that will lead to the airway dysfunction. And these airway dysfunction will lead to the obstruction, and there is limitation to the airflow. And when this remain for a long period of time, this will lead to the remodeling of the airway wall. The wall of the normal wall, you know, the histology of the bronchi, the normal wall will become remodeled. So there is high amount of smooth muscle cells, high amount of inflammation. So the narrow will become, the lumen will become the narrower. Okay, so this is the basic mechanism what we have. Genetically predisposed individual, when they get exposed to the environmental allergens, there is IgE mediated response through T helper type 2 cells. Okay, and this role of T helper type 2 cell is a fundamental abnormality seen in the atopic asthma. Okay, and this is seen maybe usually get exaggerated to the normally harmless environmental agent. That's why we have millions of, like, you are in your class, you have like around like 300 students. Okay, in that 300 students, only few of you must be having asthma. Okay, so all of you walk into these environment, but only few of them get, because why they get asthma? Because they are genetically predisposed, and in this genetically predisposition lead to type 2 helper cell mediated Ig response. So what happened? This type 2 helper cells secretes interleukin, especially interleukin 3, 4, and 5, which stimulates B cells to produce immunoglobulin E. And these interleukin also help in recruitment of the eosinophils. Eosinophils are the principal cells, inflammatory cells of asthma, and these eosinophils, how they cause bronchoconstriction? Because of secretion of these two factors, major basic protein and eosinophilic chemotactic proteins. Okay, this produce bronchoconstriction. This bring more and more eosinophils, and then more eosinophils secrete major basic proteins. Okay, so both immunoglobulin E and eosinophils are the key component of type 1 hypersensitivity reaction, which is seen in asthma in the form of acute or immediate phase and sometime as a late phase as well. So here you have this diagram. I have specifically given this lecture in the PowerPoint format. Okay, why? Because there are few notes below this picture. You will find a note. Okay, in this note there is explanation of these inflammatory mechanism of the asthma. Okay, so what it shows, here you see there is normal airway where you have a large lumen, you have lining epithelial cells, you have some smooth muscles, some cartilages and glands. Okay, whenever there is like asthma in the asthma, the bronchiole will be like this. There is like constriction of the lumen, there is remodeling of the lumen wall, there is a smooth muscle cell hypertrophy, there is increased number of glands which will produce more amount of mucus. Okay, so this is constricted airway in the asthma. Okay, and what happened in the asthma over here, you see whenever there is any allergens getting in response to the respiratory epithelium, that will get, there is activation of type 2 helper cells. These help the IgE immunoglobulin will bind to these cells, and that cells will produce various cytokines like interleukin 3, interleukin 4, 5. They will bring about the eosinophil with the help of IL-3, IL-5, granulocyte, monocyte, colony stimulating factor. These eosinophils will come, they will bring more or more eosinophils and they will release the mediators. What are those mediators? The mediators are very, very important, but I did not take mediators over here because I believe the mediators of asthma has been taken to you in pharmacology class, isn't it? Yes, the mediators, inflammatory mediators of asthma has been taken in pharmacology or not? Or it will be taken, inshallah, when you have your pharmacology lecture. That time you will find them. Are you following me?
Yes.
Yes,
Yes,
yes.
doctor.
Okay, so this is immediate phase. Within minutes, what will happen? The cells will bind. They will, the T helper cell will get activated. The Ig will bind. They will bring mast cells. Mast cell will get degranulation. These degranulation will secrete some certain mediators that will get go and act as an autonomic nervous system through the vagus nerve and cause immediate bronchoconstriction. There is also recruitment of eosinophil. Then these eosinophil or bring about certain cytokines which will lead to the edema, and there is major basic protein that will also lead to the bronchoconstriction. And later on, you will find more and more number of eosinophils, hypertrophy of the glands, and that glands will secrete the mucus. So this is what happened in a atopic asthma whenever there is a trigger in the form of any pollen or any antigen. So there is genetic factors and the environmental factor that will bring about the immune response. What will happen with this immune response? There is exaggerated T helper type 2 cells response. Okay, and this will produce certain cytokines, especially IL-4, which will stimulate immunoglobulin E production, IL-5, which will recruit eosinophil from the circulation, and IL-13, which will stimulate mucus gland in the bronchi to secrete mucus. Okay, this all will lead to this IgE. When there is IgE bind to the Fc receptor of the submucosal cells, and this will, there is repeated exposure, and that will lead to the airway dysfunction and airway remodeling. Okay, and again there is also immune response will also have some release of growth factors that will lead to the airway modeling, like in the form of mucus gland hypertrophy, smooth muscle proliferation, angiogenesis, formation of blood vessel, fibrosis, and nerve proliferation. And all together will lead to airway dysfunction and obstruction. So there are two cells. You came to know about two cells other than T helper two cells. Okay, T helper type 2 cells. You came to know about two cells. One is the mast cells, and the second one is your eosinophils. Okay, so now we have your mast cells. Okay, mast cells, whenever there is any allergy, IgE, these allergens will bind to the IgE, and these IgE will stimulate the mast cells, and the mast cells will produce these this, like what, mediators. These mediators all will lead to bronchoconstriction. Histamine, prostaglandins, leukotrienes, especially leukotriene B4, oxidants, there is enzymes, there is cytokines IL4, 5, 6, tissue necrosis factor alpha. And these mast cells can also get activated by occupational allergens, exercise, and said, like the mast cell you will see in both atopic through allergens or directly in the non-atopic, like the occupational or environmental allergens, exercise, drugs, or other irritants. And this will, mast cell will produce these mediators, and these mediators will cause bronchoconstriction. So when you come to talk about the mediators, we know there are three groups of mediators. Okay, this I have not included in the, because the lecture will become too big to include everything in it. So what are those mediators? There are three category of the mediator. One, which is very, very strongly associated with the asthma. What are these strongly associated with the asthma? Because they are pharmacologically proven. We have the treatment against these mediators and we get the symptomatic reliefs. Okay, these are the mediators are leukotriene C4, D4, and E4. And these leukotriene C, D, and E4 causes bronchoconstriction, okay, and increase vascular permeability. Then we have acetylcholine, then we have IL-5, and we have galectin-10. These are all the inflammatory mediators which are strongly associated with the asthma, and we have a specific targeted medicine against these mediators. Okay. The second group of mediators are the mediators which are not directly causing, but they are present at the scene of crime. Okay, these are these mediators: histamine, prostaglandins. Okay, so these mediators are also lead to bronchoconstriction through a neurological mechanism. So sometime in the, when you have the treatment of the asthma, you give them antihistaminic. Antihistaminic will bring down the allergic response. Okay, and the third group of mediators are usually IL, interleukin 4 and 13, and tissue necrosis factor. Okay, these are the third group of mediators, which is not very strongly associated, but associated less than the type 1, where you have the leukotriene and acetylcholine and galectin-10, and the histamine and prostaglandins are the second group, and these cytokines are the third group of the mediators. Okay, then we have the another important cell, that is eosinophil in the asthma. Okay, so these eosinophil, again the eosinophil will have the mediators. Okay, so there are cytokines IL-1, IL-3, IL-5, 6, granulocyte, monocyte, colony stimulating factor, tissue growth factor alpha, tissue growth factor beta. They also synthesize membrane or like endothelial derived mediators of the inflammation. They are leukotriene C4, platelet activating factor, prostaglandin, thromboxane B2. And they have granules of the eosinophil have very, very important two things: major basic protein and eosinophilic cationic protein or eosinophilic chemotactic proteins. Okay, so these are the two proteins which are importantly involved in the pathogenesis of asthma. So these are the two important cells: mast cell and eosinophil. Among all, If you have got any option, which of the following is the most important cells seen in asthma? Mast cell or eosinophil? What will be your answer?
Eosinophils.
Yeah, usually they
Eosinophils.
say eosinophils are the most important cells, but the mast cells are also equally important cells. Okay, so like histopathologically, you see the maximum number of cells, they are eosinophil. Mast cells you usually don't see normally. Okay, so your answer will most commonly will be the eosinophils. Okay, if eosinophils are not there, then you look for the mast cells. Okay, so just a brief revision of these pathogenetic mechanism what we learned so far. There is first thing is the genetic susceptibility. Okay, so there is like usually other in allergic disorder will be there like allergic rhinitis and eczema in this patient. Okay, and in where this locus or where this gene is located, this gene is located on the short arm of the chromosome 5 or chromosome 5q, and this is located very near to the cluster of the gene which is encoding for the cytokines IL-3, IL-4, IL-5, IL-9, interleukins. Okay, interleukin 3, 4, 5, 9, and 13, and interleukin 4 receptor. Okay, and among all the genes in this cluster, polymorphism in the IL-13 gene have the strongest and most consistent association with asthma or allergic disease. Okay, so genetic susceptibility genes are located on the chromosome 5q, and they are close to all these cytokines forming genes 3, 4, 5, 9, and 13, and among all interleukin 13 gene have very strong association with asthma and allergic diseases, while IL-4 receptor gene variants are associated with atopy and elevated total serum IgE. Okay, so whenever you see high level IgE, it is due to the interleukin 4 receptor. Okay, and allergic diseases and asthma, it is due to interleukin 13. There are also class 2 HLA human leukocyte antigen alleles, which are linked to the production of IgE antibodies against some antigen like ragweed pollen. Okay, this is like a special type of weed, and pollen of this weed can also lead to the development of asthma, and that is seen in this class 2 HLA. Okay, to make it easy, this is just for the extra knowledge I have added this point. Okay, so only thing you have to remember, IL-13 gene has the strongest association with the asthma and the allergic disease, and IL-4 receptor is related with the serum IgE. These are the two important points you will find in this slide. And genetic susceptibility, we have already told initially also. Whenever you see the atopic asthma, there is always a genetic susceptibility. Is there any question?
Can you repeat the most two important things there?
Okay, so see what is over here. There is a genetic susceptibility always. Okay, and where this gene is located for the asthma genetic susceptibility, chromosome 5. And these chromosome 5q also have the genes for these cytokines 3, 4, 5, 9, and 13, and receptor for interleukin 4. Okay. Among these, all the number of 1, 2, 3, 4, whatever number are there, interleukin 13 have the strongest and consistent, means most consistent association with asthma or allergic disease. Okay, so if you see among all, for which of the following interleukin gene is strongly associated with the asthma, your option will be 3, 4, 5, or like 5, 9, 7, or 5, 9, 7, 9, 11, 13. What will be your answer?
13.
13.
13.
Yeah, so that is why we say, even though you can get all these options also 3, 4, 5, and 13. Again, your option will be 13 only. You cannot say it is associated with this also, this also, this also. But what is we are asking the strongest association with interleukin 30. Okay. And while elevated total serum IgE elevation is related with the IL-4 receptor gene. Okay. So this IL-4 receptor gene is responsible for the elevation of IgE in a patient of asthma. Okay. So these are the only two important points over here. So we have the main pathological mechanism in asthma is inflammation of the airway. These inflammation can be induced by either allergens, chemical sensitizer, environmental pollutants, or viral infections. Okay. What will they, or there is genetic hypersensitivity. Okay. So all these two will bring what there is other triggers also, as you see in the like exercise, temperature, sulfur dioxide particulates. Okay, this is part of air pollutants. Okay, so these are all, this is like atopic, non-atopic, atopic, environmental, everything bringing inflammation, and these inflammation will lead to obstruction, bronchoconstriction, obstruction to the airflow, and will produce symptoms of the asthma, cough, wheeze, breathlessness, and chest tightness. So this is about the pathogenetic mechanism of the asthma. Now we go to the morphology. Morphology was what you see in the organs of the lung and bronchi, and what you see there in the gross, like in the organ or during the microscopic slide. Okay. So when usually you don't see the gross lung normally. This is generally seen a person who has died of the asthma, and you got a chance to do the postmortem examination in that person, and you can see the gross changes. Okay. So usually what happens, sometime patient comes in the acute, very severe acute asthma, and he died without any treatment in the ear. Here in Saudi Arabia, it is not very common, but in Western countries and India, if someone is coming to the hospital and dying within 24 hours, you don't know the proper cause of death, you send them for autopsy. So in that case, you see the lungs are large, overinflated, and some areas of atelectasis. Say the most striking gross finding is the occlusion of the bronchi. If you open the bronchi, you see the bronchi are occluded by the thick, very tenacious, very like thick, very gelatinous mucus plug. And this mucus plug, if you examine under the microscope, you will find like respiratory epithelium attached to this mucus. Okay. And sometimes you might get a bronchoalveolar lavage if a patient is admitted and you do bronchoscopy and you wash the bronchial and alveoli. You get that water and you send it for the pathological examination. In that, if it is a case of atopic asthma, you may see the Kirschmann spirals. Okay, what are these Kirschmann spirals? They are nothing but the mucus plugs which has some which comes from the subepithelial gland. Okay, and these Kirschmann spirals also will have the eosinophils and charcot laden crystals. Okay, and these charcot laden crystals are usually made up of the eosinophil dried protein galactin 10. This galactin 10 is a very important mediator. Okay, strongly associated mediator. Okay, so what is this? This is how the lungs will look. As soon as you open the chest, the lungs will bulge, hyperinflated lungs. And this is the mucus plug, okay, which we call the Kirschmann spirals. Okay, and when you examine them under the microscopy, you will see the eosinophil, epithelial cells, Kirschmann spirals, charcot ladle crystals. Microscopy, the
Doctor,
yes, please.
Gross, how can see oxidation of bronchial asthma?
Yeah, gross, like you will cut open the lung. Okay. Once you see the lung, you take out the lungs from the dead body, and then you cut open and see what is the abnormalities, is there any obstruction, because your patient has come with the breathlessness. So is there any obstruction? So you will find the small bronchioles or bronchi filled with this type of mucus. See, this is the, like you find it is like, it is exactly from the trachea. You find it is like, this is in the trachea, this is the left and the right bronchi and the small bronchial tree. Sometimes you might get this type of finding also. Okay, you need to cut and see. Okay. And then you take the small piece of this lung and bronchial, you make the slide and you see this changes. And these characteristic histological finding of the asthma is called as airway remodeling. And what do you mean by these airway remodeling? Okay, there is thickening of the wall, thickening of the bronchial or airway wall. There is fibrosis, especially in the subbasement membrane due to deposition of type 1 and type 3 collagen. There is increased vascularity, increase in the size and number of the submucosal gland, okay? Increased number of goblet cells, hypertrophy or hyperplasia of the bronchial wall, smooth muscles with increased extracellular matrix, okay? So airflow obstruction is usually attributed to the muscular bronchoconstriction, then edema and mucus plugging. And airway remodeling is no, or it's the cause for the irreversible airway obstruction. That's why you see in the asthma, you will not get, even with the treatment, you will not get the normal flow to the air. There is always some degree of obstruction there. And these obstruction because of the long standing asthma leading to the airway remodeling. Okay, so this is the normal epithelium. You have respiratory epithelium, you have basement membrane, you have lamina propria, you have smooth muscle cells, you have gland and cartilage. Okay. In bronchial asthma, you will find the eosinophil, very characteristic, mucus in the lumen, goblet cell hyperplasia, thickness of the basement membrane. You will find inflammatory cells. Again, the eosinophils, macrophages in the lamina propria, submucosal gland hypertrophy, smooth muscle cell hypertrophy. And this is a very characteristic finding, which like we have the colored arrow, which is showing different things. Okay, so you have goblet cell hyperplasia, hyperplasia of the goblet cell, and this goblet cell hyperplasia will cause excessive mucus production. Okay, subbasement membrane fibrosis, which is indicated with the black arrow. Okay, yellow arrow, or sorry, I have got, there is like some change in the color of this arrow. Okay, the yellow arrow will show the eosinophilic inflammation. Okay, here you just change it in your lecture. Okay, blue arrow is for the eosinophil and muscle hypertrophy is yellow arrow. Okay. Okay, this microscopic picture is clear to you. Okay, so here eosinophilic inflammation we show with the blue arrow. Okay, or just give me a minute. Okay, so eosinophilic inflammation and smooth muscle hypertrophy. These are the remodeling features shown in this microscopic slide from a patient of the bronchial asthma. And this is the schematic representation between the normal and bronchial asthma. So we have now environment and asthma. Okay, as you know, in asthma is nowadays they say asthma is the disease of industrialized societies. Okay, it is seen more in the city life, not that common in the rural areas. So why you say there are two things. Okay, first, the industrialized environment or the life in the city contain many airborne pollutants. Okay, and these airborne pollutants can serve as allergens to initiate the T helper 2 response. Second thing why we see that the asthma is a disease of industrialized society, it is there is like in the city life, there is little exposure of the young children to the certain antigens, especially the microbial antigens, because we keep our children in the city life in a very hygienic condition. So sometimes excessive hygiene is also not good for your baby. Okay. So especially some good, they are like when we protect them from bad bacteria, we protect them from some good bacteria also. And these, if they get exposed to these good bacteria, can protect them development of the asthma. But in the city life, due to excessive hygiene, there is little exposure to the microbiome, especially the good microbial antigens. Okay, so one is the excessive environmental pollutant, and the second is little exposure to the good microbial antigens. Okay, so this is, that's why I say the asthma is an environmental disease. Okay, and they say like there is infections and asthma are related, but infection usually does not cause asthma directly, but they are a cofactor, especially in the children who are susceptible or who are like sensitized to the allergens. They are more prone to develop respiratory tract infection. Why? Because asthma causes what? Edema. There is accumulation of the fluid, and this fluid will lead to excessive infection because they provide nutrition to the viruses. And these are the two viruses, rhinovirus type C and respiratory syncytial virus, have very increased risk of this. Okay. And sometimes we say a lot of asthma, eosinophil, but especially there is a type of asthma which like have a severe disease and they don't get response to the glucocorticoids. And their inflammatory infiltrates are rich in neutrophils instead of eosinophils. And here they will not T helper 2 cell, but instead they have T helper 17 T cells. Okay, this is a very new recent finding they have seen. The patients with the children or the adult patient, they have asthma, but they don't get treatment with the or respond to the glucocorticoid. With excessive research, they found they don't have the eosinophils, they have neutrophil, and their principal cell of inflammation is T helper 17 type of T cells. Okay. Clinical features I skip here to save time. You will read it and you will know in the case review also clinical feature of asthma. Okay. Complications. The most common complications of the like bronchial asthma are usually emphysema. Emphysema is the most common complication of bronchial asthma. Other they may have because of the like airflow obstruction. They may have hypoxia, arrhythmias, lung collapse and atelectasis, pneumothorax, call pulmonale, respiratory failure, congestive heart failure, or psychological problems. Okay, so this is about the bronchial asthma. I hope this bronchial asthma is clear to you all.
Yes, doctor.
Yeah.
Yes.
Can you repeat what the relation between T helper and asthma?
Yeah, T helper, especially T helper type 2 type of helper cells, they are the cells which get activated by immunoglobulin E. Okay, these whenever these T helper cell get activated, they produce various inflammatory cytokines, especially interleukin 3, 4, 5, interleukin 13, granulocyte, monocyte, colony stimulating factor. Okay, once that get activated, this will cause these inflammatory cytokines will bring two important cells. One is eosinophil and another one is mast cells. And these two cells will produce again leukotriene B4, C4, D4, histamine, prostaglandins, and this all together will lead to the bronchoconstriction. These some of the cytokine also will lead to activation of the submucosal glands, hypertrophy of goblet cells, and smooth muscle hyperplasia. And that will lead to remodeling of the airway wall. Okay.
Okay, doctor, clear.
Okay. So now we go for the acute lung injury or ARDS or diffuse alveolar damage. Okay. It is characterized by abrupt, like sudden onset of hypoxemia and bilateral pulmonary edema. Okay, there is bilateral pulmonary edema in the absence of cardiac failure. So this is one of the commonest cause of non-cardiogenic pulmonary edema. If a patient has cardiac failure, you cannot call it as a ARDS. Okay. Acute respiratory distress syndrome is a manifestation of severe ALI. ALI is acute lung injury. When it becomes very severe, we call them ARDS. Both ARDS and ALI are associated with inflammation, associated increase in pulmonary vascular permeability. There is inflammation, and these inflammation is leading to the increased vascular permeability. So what happens when the vascular permeability increases? The fluid from the vessel or plasma will come into the lung parenchyma. This will lead to edema, and these edema will cause pressure on the epithelial cells of the alveoli and lead to epithelial cell death. When the lung epithelial cells are dead, there is no exchange between the carbon dioxide and oxygen. So patient will have hypoxemia and hypercapnia. Okay. And these epithelial cell death is characteristically histologically manifest as diffuse alveolar damage. That's why it has three names. Clinically, we call it ALI or ARDS. Pathologically, we call it as the DAD, diffuse alveolar damage. Okay, so what is there? There is inflammation. These inflammation lead to increased vascular permeabilities. There is intraalveolar edema, epithelial cell death. Okay. And it is a well recognized complication, very commonly seen abnormality in ER. Okay, and not a single condition causes. There is a list of condition which can cause a acute lung injury that could be either from the lung or systemic disorder. And in some of the instances, very uncommon, very rarely, this is ALI can be seen in absence of any trigger and follow a very rapid progressive clinical course. And that time it is known as acute interstitial pneumonia. Acute interstitial pneumonia is a type of ALI or ARDS only, but here we don't find any trigger. We don't see any systemic or pulmonary disorder, and the progress is very severe over here. Okay. So these are the causes, like we have infection, injury, especially the head injury, infection, septicemia, diffuse pulmonary infection like pneumonia. Okay, gastric aspiration, especially someone is in coma, aspirate the gastric material or gastric juices, gastric aspiration, and head injuries. Okay, mechanical trauma to the chest or the head injuries. These are the four very important causes for the acute respiratory distress syndrome. And in the ER, you will find head injuries, sepsis, pneumonia, and gastric aspiration commonly occurring diseases in this. And these commonly occurring diseases will lead to acute respiratory distress syndrome. And there is a big list. Okay, you have the inhaled irritants, chemical injuries, hematological conditions, especially if you have like transfusion. Sometimes some patient who get blood transfusion, they develop due to some allergic response, transfusion associated lung injury, trolley. And this is a very severe complication of blood transfusion. A simple transfusion can change into the trolley. Okay. Then you have the case of pancreatitis, uremia, chronic renal failure, cardiopulmonary bypass, or hypersensitivity reaction. Also, you can see the ARDS. So this is a big list, but among this big, sepsis, diffuse pulmonary infection, gastric aspiration, and mechanical trauma or head injuries are the most common cause for the ARDS. Okay. Pathogenesis, as I told already, there is injury to the pneumocytes and pulmonary endothelium. Okay, so there is activation of the endothelial cells. There is adhesion and extravasation of the neutrophil from the circulation. They come inside the alveoli. There is leakage or increased permeability of the vascular. So there is accumulation of intraalveolar fluid and formation of hyaline membrane. So formation of hyaline membrane is a very characteristic feature of ARDS. Okay, so hyaline membrane disease, one seen in the newborn, other you see in the adult, usually in the cases of ARDS, and it's a very characteristic form. Okay, so And once this patient survive these events, there is a resolution. Okay, resolution may lead to the formation of fibrosis. Okay, with the help of tissue growth factor, transforming growth factor beta, tissue growth factor alpha, fibroblast, and platelet growth factor. So this is your normal. You have the respiratory epithelium, you type 1 pneumocystis, type 2 pneumocystis, normal surfactant, you have like interstitium and your blood vessels. This is normal. What happened there was like injury to the epithelial cell, disruption of the surfactant, necrosis and depth of the type 1 pneumocystis. There is increased vascular permeability, excessive accumulation of fluid and the neutrophil in the interstitium, in the alveolar parenchyma, edema, there is deposition of fibrin, there is role of macrophages, and eventually there is type 2 pneumocyte injury, which will lead to the formation of hyaline membrane. Okay, so you have two phases in acute exudative stage and in the proliferative or organizing stage. Okay, in the acute exudative stage, you have the lungs are heavy, firm, red and boggy. Okay, there is like a formation of waxy hyaline membrane. Okay, in the proliferative phase, this is the mainly due to the involvement of the type 2 pneumocyte, which proliferate and lead to the formation of the granulation tissue. There is deposition of the certain uh, collagens and extracellular matrix also due to certain fibroblasts, and the platelet derived growth factor lead to the thickening of the alveolar septa. So this is your microscopy. You have like what you see over here, hyaline membrane, especially the formation of the hyaline membrane, which is a characteristic feature of the diffuse alveolary damage or acute respiratory distress syndrome. Clinical feature, as it is acute, there is very severe and very rapidly progressing dyspnea associated with tachypnea. Okay, so what do you mean by tachypnea? Higher respiratory rate, normal respiratory rate, it is more than that, and patient along with that patient have difficulty in breathing. Okay, then there is, which will followed by respiratory failure, hypoxemia, hypercapnia, cyanosis, and when you have the X-ray, there is appearance of diffuse bilateral infiltrate on the X-ray chest. And this hypoxemia is refractory to the oxygen therapy. Why it is refractory? Usually when you see hypoxemia, you give oxygen, it get corrected. But in the ARDS, this is not get corrected with the oxygen therapy. Why there is? Because there is ventilation perfusion mismatch. So this is the again, one of the important finding of ARDS is ventilation perfusion mismatch. And there is no specific treatment for ARDS. You need to treat the supportive treatment and treat the cause. If there is a sepsis, treat the infection. If there is a injury, treat the injury. Okay. If there is aspiration, you need to follow the treatment. Treat the cause. This will resolve with the treatment of the cause. This is the phase acute injury, latent period, acute respiratory failure, and the severe abnormalities. Complication, because there is edema, there is infection, there is formation of pulmonary emboli. Because it is refractory to the oxygen, we try to give more and more oxygen to treat the hypoxemia. So there is oxygen toxicity. There are chances of gastrointestinal hemorrhage, gastric distension. This gastric distension may be related to the oxygen toxicity. There is like infection, which will lead to sepsis causing ARDS and ARDS causing sepsis. Okay. There is disseminated intravascular coagulation, pulmonary. If the patient survive, there is pulmonary fibrosis and cardiovascular problem. So here we finish our lecture. Okay, this lecture was like because of the two important topic we need to discuss. So we took little bit more time. I request you to read it again. Our reference is Robbins 10th edition. Okay, Robbins Pathological Basis of Disease.